Hello everybody. Today I'm going to speak to you about a case of a grade 3 adenoid hypertrophy in which I perform coblation adenoidectomy. Here you can see that it's a small child with grade 3 adenoids, and this is the nasal endoscopy findings. You can see the adenoid tissue in the nasopharynx visualized with a 2.7 mm rigid endoscope, 0-degree endoscope, which I insert through the both the nasal cavities one by one. And here I'm using the coblation wand, which is called tonsil blata plus. It has two electrodes. It's a very special wand, and it's an aggressive, powerful wand with a very wide suction port which doesn't get blocked, because normally adenoidectomy surgeries with coblation, the main challenge is that because of the bulky tissue, the suction port often gets blocked and one has to unblock it repeatedly. That way it increases the surgical time. But this is a beautiful wand which has a wide suction port with two electrodes, and irrigation is from the side. So it cuts very well. It melts the adenoid tissue like butter, and it hardly gets blocked during the surgery. Almost we can finish the entire surgery at one go. So adenoidectomy using the coblation is a very easy method of doing the surgery. As you can see that this coblation tool has 4 functions: coblation, coagulation, irrigation and suction, all in one tip. It's designed very beautifully to do all the 4 functions. Hence, we can directly visualize the adenoid tissue and do a very precise and a very clean adenoidectomy in a bloodless field with very little chance of recurrence. So with this coblation adenoidectomy, the chances of recurrence of symptoms like snoring, mouth breathing, regrowth of the adenoid tissue is very, very minimal, provided we do a complete adenoidectomy. So here I'm doing it from superficial to deep, going layer by layer. As you can see that I'm holding the adenoid wand like a paintbrush and keeping a few millimeters gap between the coblation wand tip and the tissue, where the plasma ions are created with the help of the flow of the electric current through the saline, which converts it into the plasma ions. You can see the orangish flame very well, and that is what does the dissection. So one must be able to visualize the electrodes at any time. We should not bury the electrode tip into the adenoid tissue. That can lead to blockage. So keep a few millimeters gap and always see the tip of the electrode when doing the surgery. And one can go in horizontal strokes or vertical strokes. And layer by layer, the adenoid is removed from the basis sphenoid superiorly to the passivans ridge inferiorly, and laterally the limits are from one fossa of Rosenmuller to the other posteriorly, and anteriorly from one torus tubalis to the other. So these are the limits of adenoidectomy. So when one choana, we can visualize the adenoids and remove the adenoids completely. We then insert it through the other nasal cavity and remove the adenoids. The choanal adenoids also have to be removed completely from floor to roof. So this way we can ensure that no bit of the adenoid tissue is left over, because in children, especially 3 to 5 years age group, if we leave behind adenoid tissue, then there can be a regrowth of the tissue, that is hyperplasia can occur again, because after all it's lymphoid tissue, and the child may have an initial improvement with the return of snoring and mouth breathing again within 1 to 2 years. So since we do not want that as surgeons, we must do a complete job. Especially in children who have known allergies, then the regrowth of the adenoid is very notorious, and so that's why one must completely remove the adenoid tissue till we can expose the buccopharyngeal fascia posteriorly. So till we come to that plane, we have to ensure that we have removed the entire adenoid tissue. And why I'm emphasizing this over and over again in my video is that because you have seen a lot of adenoid videos in my channel, but I wanted to emphasize 2 important things in this video. One is the use of this beautiful wand, which is a tonsil blata plus wand, or in the Smith & Nephew company it is called as the ProSize Max wand. This is the Bonds wand which I'm using, which is called tonsil blata plus. And you can see that very gently I'm removing every bit of the adenoid tissue. When one comes to the roof and the lateral wall, we have to be very careful or we can encounter bleeding. So because this is a very aggressive wound, so feather touch is what is indicated, and leaving a few millimeters gap between the wound tip and the adenoid tissue is another important tip for the beginners. We must of course spare the passivans ridge while doing the surgery, otherwise it will lead to nasopharyngeal incompetence with regurgitation of fluids when the child drinks water or any fluids, and a nasal twang to the voice because of rhinolalia aperta, that is nasopharyngeal incompetence, velopharyngeal incompetence, that is. So one must spare the passivans ridge, that is a horizontal layer of muscle present at the inferior aspect of the adenoids, which actually closes the nasopharynx when one swallows, and we should not violate that. This is, I'm gently removing the lymphoid hypoplasia over the torus and then taking out the little bit of adenoid tissue which is present superiorly in the choana, roof of the choana. So all these little bits have to be removed completely to ensure a very good result, and so that the child becomes free of snoring, mouth breathing, drooling, and has a good sleep and improved appetite, and will be free from recurrent episodes of cold and upper respiratory infection, because enlarged adenoids child will be prone to repeated URI and also recurrent otitis media because of the blockade of the eustachian tubes. So again here the excess lymphoid tissue on the torus leads to blockade of the eustachian tube orifice. So one must be meticulous in removing the adenoid tissue there so that the eustachian tube orifice becomes very wide open. At the same time, one must not injure the eustachian tube orifice, because any kind of injury can lead to scarring and narrowing of the ET tube orifice, which can lead to more harm, and recurrent episodes of otitis media. So one must be careful there also. So again, you can see that little bit of adenoid tissue which is present in the roof of the choana, which I'm removing very gently. This is the area which can cause bleeding if one is not careful. So a feather touch at any point of time, you can see that I have left a few millimeters gap between the adenoid tip and the tissue. I mean the coagulation wound tip and the tissue. And copious irrigation with saline is very important, because it is a saline which is converted to the plasma ions by the passage of the current through the electrodes. And it is these plasma ions which break the covalent bonds in the protein molecules of the adenoid tissue, leading to disintegration of the adenoid tissue and ablation. That is the basic principle of adenoidectomy, which one must understand. So one must not bury the wound tip in the tissue. And also intermittent ablation is important, because that causes more generation of plasma, because the current circuit which opens, makes and breaks, so that's a circuit is formed and the plasma is generated, and then again no further plasma is formed. So if we keep intermittently using the ablation mode, then more and more plasma will be generated.